Welcome to another episode of the PFC Podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
Hey, this is Doug with the Prolonged Field Care Working Group, and today we're going to be talking about burn wound management and the new Joint Trauma System Prolonged Field Care Burn Clinical Practice Guideline. Okay, so one of the first principles of burn management are that burns that are over 20% of total body surface area are potentially life-threatening, and the other burns that you need to take seriously in terms of management and because of complications and the need for expedient evacuation are any burns that involve the airway or cause breathing problems, and then any burns that place limbs at risk, such as circumferential burns to the hand. Even in the ICU and in a trauma center, burns are pretty complex things to manage. So if you have an opportunity to engage experts by telemedicine, you should do so early. There are also really visual problems, and the ability to take a picture and send it to an expert in burns can really help both engaging the burn size and severity and then in the management of that burns. For those of you in the U.S. Department of Defense, the Burn Center at the U.S. Army Institute for Surgical Research, or ISR, have dedicated numbers that you can call for burn teleconsultation, and these will actually also help you arrange evacuation of seriously burned casualties, and they're shown in the slides, both the numbers and a direct email. So the first thing to address when you're looking at burns, the first question to answer, yes or no, is there airway involvement or threatened airway involvement? And the big reason to do this with burns is that what can look like a benign airway early on can become to threaten airway later as you resuscitate the patient and the airway swells. Patients that are at risk for an inhalation injury are those with any evidence of burning around the mouth or singeing around the mouth, or if they have symptoms when you first come on them. And some of the common symptoms are going to be coughing, respiratory distress, so they're having difficulty breathing, they're tachypnic. Any stridor, which is wheezing with inspiration, is a pretty serious sign. And these are, in general, in prolonged field care, we talk about being careful before placing a definitive airway, because placing a definitive airway involves a lot of management, right? You have to have somebody bag, you certainly have to have some medications to keep the patient comfortable, and so it's not something to be taken lightly. But in burns, it's better to err on the side of caution and take an airway early, because later on you may not be able to place an advanced airway because of the swelling, both around the neck if you're placing a crike, or in the larynx if you're placing an endotracheal tube. You'll see on the slide kind of a minimum, better, best recommendation for airways. I would caveat this by saying our recommendation is always to place the advanced airway that you feel best trained to get in place without complication. And so if you're more comfortable placing a crike, then place a crike. If you're more comfortable placing an endotracheal tube, place an endotracheal tube. A couple of things regarding endotracheal tubes in prolonged field care in general, and then one in burns specifically. In general, you're going to need more medications to sedate your patient with an endotracheal tube because of the stimulation of the gag reflex. So before you place one, make sure that you have the medications to support keeping your patient comfortable. For burn stuff specifically, because the airway can become pretty rapidly distorted with swelling and even with debris that's been inhaled, having a bougie along with you so you can have a little bit more confidence that the airway is going in the trachea the first time can be a real lifesaver and a real asset. And bougies are, they're light, they're they're really portable, and I think if endotracheal tube is going to be an option in your airway algorithm, I would almost recommend always carrying a bougie in a prolonged field care environment. Here's a slide that kind of shows how distended and distorted an airway can become This is a patient who's had an endotracheal tube placed and a significant amount of resuscitation that's caused swelling of the face and the neck, and that would be really, really difficult endotracheal tube to place and a really difficult crike to place because the landmarks are distorted to the point of potentially not even being there. Once you've made a decision whether the airway is protected or needs to be protected and moved on from protecting it if you need to, the next step is to assess both the burn size and severity, because this is going to guide both the risk to your patient and the resuscitation. And there are all sorts of charts that show the rule of nines and how to calculate burn size. This is one of the areas in burn patient treatment where we see quite a bit of difficulty getting it right, and engaging a more trained provider or additional providers can really be helpful. In general, people tend to overestimate burn size and overestimate burn severity. And the so what of that is that patients can receive too much fluid and too much resuscitation, and there are complications to that, as we'll talk about a little later on. So if you're on your own, you have to rely on your charts. I'd save these as a PDF or something on your smartphone or your tablet. If you have the chance to take good photographs and send them to a burn center, they can be super helpful getting the calculation right the first time. And if that's going to be delayed, make your best estimate, start your resuscitation, and then get consultation when you can, and you may wind up realizing that you can revise your resuscitation needs downward based on a downward revision of your burn size. So severities, we talk about first degree, second degree, third degree burns. That's kind of the popular or the common terms. What we're really talking about are superficial, partial thickness, and full thickness burns. There are all sorts of terms out there. What's important to know, I think a couple things that are important to know about burn severity is, number one, second degree burns or partial thickness burns are the ones that are going to hurt, right? And so if you have a significant amount of partial thickness burns, you're probably going to have a significant amount of pain medicine requirement or analgesia requirement, because the nerve endings are exposed but not burned. And their nerve endings terminate in the skin, and that's why wounds to the skin can hurt a lot. Full thickness burns, the nerve endings have been destroyed and they actually don't hurt that much. Your pain requirements shouldn't be that high. Burns around the fingers and the hand are particularly concerning. The hands have a lot of nerves and obviously a lot of function, and any circumferential burn, full thickness burn around the hand will probably need escharotomies. That's another point to make about burn severity as well, is that only full thickness burns could require escharotomies. Partial thickness burns are flexible enough that they would not require an escharotomy. So you'd be looking to do escharotomies on full thickness burns that are compromising some sort of physiologic performance, and we'll talk about that in a minute. On the right in this slide, you see this is a young child who's probably had a scalding injury, and you can see the full gamut of superficial, deep, and intermediate thickness, partial thickness burns. Here are a couple pictures of a patient with full thickness burns on the upper extremity that have required escharotomies both to the upper arm, the lower arm, and the back of the hand to relieve pressure and the risk for compartment syndrome. And another picture of a blast patient who's got extensive partial and full thickness burns. Would probably be requiring escharotomies of both of these lower extremities, and most likely the thorax, if you can see how deeply scarred that thorax is, in order to allow the patient to ventilate, to relax and ventilate. Once you've calculated your burn size and severity, or the hallmarks of burn care are volume resuscitation for fluid that is lost through the loss of barrier protection, and infection prevention. So we recommend there are all sorts of formulas out there for burn resuscitation in terms of how much fluid you're going to get over how much time. The clinical practice guideline, the CPG, recommends using the rule of tens, mainly because it's pretty easy math, right? It's the burn size in percent times 10 is your initial fluid rate per hour. So if you have a 40% partial or full thickness burn, times 10, 40 times 10 is 400 cc's an hour of crystalloid, preferably Ringer's lactate or plasmolite, is going to be your initial fluid rate. The main thing to talk about when we talk about fluid resuscitation is that all of these formulas are giving you an initial starting point, and some of them maybe some catch-up for the amount of time the patient has been under-resuscitated, but they are not a goal to be hit over 24 hours, right? So if the Parkland formula says, you need to give your patient 12 liters, 6 liters in the first 12 hours and 6 over the next 12 hours, the goal isn't to give the patient 12 liters. The goal is to start, assess their responsiveness, and then either increase if they're not responsive and back off if they are responsive. And the responsiveness that we're looking to assess is urine output, right? So I think I get to that in a couple of slides, but it's really important to know that all of these recommendations are just a start point, and that along with basically the reflex should be, as you start fluids, you should be putting in a Foley catheter so you can monitor the response to fluids. And that's really the muscle memory that you should ingrain for burn resuscitation. There are other ways to resuscitate fluid losses due to burn or burn shock. There's data that support enteral fluid replacement, both by nasogastric tube and orally. In prolonged field care, we don't recommend routinely putting in a nasogastric tube because you don't have a chest x-ray to confirm its placement, and the risk of a misplaced nasogastric tube is that it goes, not down the esophagus, but down the trachea and into the lungs. And if you think resuscitating a burn patient is tough, try resuscitating a burn patient who's gotten a whole slug of fluid down in their lungs. So if they're awake and alert and can take oral water or oral fluid, then oral resuscitation for burns up to about 30% has been documented. And if they're not, rectal fluid would be our recommendation for an alternative enteral fluid administration route in prolonged field care setting, because you're not going to run into the same complication putting in a rectal tube as you would putting in a nasogastric tube. A super important point is that the fluid that you give orally or rectally has to be an electrolyte solution. It cannot be free water. Plain water given in the volumes that it takes to resuscitate a burn will cause a life-threatening drop in your serum sodium. It will dilute your sodium down to the point where your patient can have seizures, go into a coma, and die from cerebral edema, because the water in the brain cells will be so much saltier than the water in the bloodstream that water will diffuse out of the bloodstream into the brain cells down the sodium gradient, causing swelling of the brain cells, cerebral edema, and death. So it's not difficult to do an electrolyte solution. You can use a World Health Organization solution. You can add a quarter teaspoon of sodium and a quarter teaspoon of baking soda to a liter or a quart of Gatorade. If you don't have the bicarbonate or the baking soda, you can just double that and add half a teaspoon of sodium and give that. Interestingly, our colleagues at the burn unit and the Institute for Surgical Research down in San Antonio are giving some of their burn patients oral resuscitation preferentially over IV, because it's thought that it would stimulate the motility of the gut and avoid the ileus or the paralysis of the gut that can happen in shock. And they're getting some decent results out of there. So this might be a case where prolonged field care research and clinical practice guideline development is informing our clinical colleagues. More to come on that, probably in a future podcast or in a Q&A about burns. The main monitoring that you need to be done with burn patients are, as with any critically ill or critically injured patient, the vital signs and exam monitoring to spot decompensation, because these are patients who are at risk of decompensating from hypovolemic shock. and also, but most importantly in these guys, urine output to assess their responsiveness to your fluid resuscitation to see if it's adequate and you can back off, or inadequate and you need to bump it up. So we kind of talked about the importance of placing a Foley catheter early. Your urine output goals really don't have to be all that high in burn. 30 to 50 cc's an hour is fine. And better really to have a lower urine output and use less fluid and have less risk of the complications of compartment syndrome from over-resuscitation or pulmonary edema from over-resuscitation than to shoot for a higher urine output and court those risks, at least in a PFC setting. The one caveat to that is electrical injury. So if somebody's burned because they've had a major electrocution, there you've got really a component of crush injury and rhabdomyolysis that's complicating the picture. So not only do you have the skin losses and the plasma losses through the skin that you do in burns, you have the muscle injury and the myoglobin release that can clog the kidneys, causing kidney failure and even permanent injury that you do in crush or traumatic rhabdomyolysis, which is the topic of another clinical practice guideline. So in those cases, you treat the rhabdo component of the burn by targeting a higher urine output of about 100 cc's an hour. Not quite as high as we recommend in pure crush, of 200 cc's an hour, but certainly higher than we do in burn. So for extremity burns, kind of talked about a little bit already, that they're vulnerable to compartment syndrome from circumferential full thickness or third degree burns. And so there are a bunch of ways you can treat that. At a very minimum, you can elevate the heart, the extremity above the level of the heart to kind of drain some of that swelling. You can cool them gently, not direct ice, but at least leave the extremity out and cooling, which is kind of ironic given that we want to keep burn patients warm in general because of the loss of skin and barrier protection and the risk of hypothermia. But if you can locally expose a threatened extremity and keep it cool and the patient's temperature normal, then do that. If you can't, the tiebreaker goes to the overall body temperature, right? Because a lot of our burn patients are polytrauma patients, and hypothermia is the enemy of coagulation and trauma. So better to keep the extremity warm, to keep the whole body warm, and deal with the risk of compartment syndrome with escharotomies. So, escharotomies are basically following the lines of flexion around all major joints. Here's a gross schematic on this slide. And then also another place that we worry about compartment syndrome a lot is thoracic, impeding the ability of the lungs to inflate and absorb air. And if you have a patient, usually a patient with thoracic burns that are that significant is probably going to have some facial involvement, and they're going to be intubated or have a cric and be on a ventilator. And what you'll notice as a potential warning sign is the pressure alarms start going up on the ventilator as it becomes harder and harder to expand that chest wall against the rigidity of a third-degree burn, and then you would perform escharotomy. And there's some diagrams that are shown in the slides that will accompany this talk on the website. In the hospital, we perform escharotomies with bovies, with electrocautery, so the bleeding is relatively well controlled. You probably won't have that in the field. And so the next slide shows an escharotomy that's performed with a scalpel, and the point of this is to show that it bleeds a lot more. Will you lose enough blood that you compound the hypovolemia? Potentially. So that's a consideration, but the limb wins out over that, and you just have to up your resuscitation. What I would say is that this should be a two-person operation. If you can get a second pair of clean hands in there to go behind the medic with the scalpel or the person with a scalpel with some hemostatic dressing, and just kind of have that in a ribbon packing the wound as they perform the escharotomy. And that should generally control the bleeding relatively well, especially if you don't have any acidosis or hypothermia. And then you may have to change that dressing once or twice when it soaks through, but eventually that'll be controlled. But just I guess the main takeaway for that is be prepared for a significant amount of capillary bleeding with an escharotomy done with a scalpel, and have a plan in place to manage it as it happens. So, like I said earlier, burns can hurt or they can't hurt depending on how severe they are. And ironically, the more severe the burn is, the less it's going to hurt. But significant second degree or partial thickness burns are going to, they definitely fit that definition of complex analgesia or complex pain in the pain and analgesia or pain and sedation clinical practice guideline. And will chew through a lot of your pain supplies if you don't plan it. These would definitely be people that I would try to get on a drip earlier, so you can get them on a plane of analgesia and keep them there, and knowing that you may have to bump them with almost procedural doses of, well, in fact, we'll get to this in infection control, but you will have to bump them with procedural doses of ketamine when you do anything like cleaning or debriding the burns. But put them on a drip early, a ketamine drip, some bumps of midazolam, every 30 to 60 minutes if they're having delirium side effects, which are more common than not. That would be my recommended plan for pain management in these patients. Interestingly, even though infection is really one of the biggest risk of burns, there's nothing in the literature and nothing in the guidelines for really advanced burn centers that says go ahead and put them on prophylactic antibiotics. Infection control and burn management is really all about source control. So it's get them clean, keep them clean, put a barrier between the skin and a contaminated environment. So in a PFC situation, your optimum burn care is going to be to put on, some sort of a burn care dressing, like Silvadene, sulfamyelin, or Silvalon dressing, after cleaning the wound thoroughly. And so to clean the wound, we recommend something like Hibiclens, which is chlorhexidine. Even soap and water is better than nothing, but know that this can cause a significant amount of pain, and you're going to need, that 2 milligrams per kilogram body weight ketamine dose. So, for instance, 200 milligrams of ketamine every 30 minutes or so in a 100 kilogram guy until the procedure is complete. You really need to put them on almost like a TIVA plane to do this. If you can't do it because your environment's just too dirty that getting them clean isn't going to really help, or you don't have the time, or you don't have the supplies, or you don't have the dressings, just covering them with a clean sheet is a lot better than nothing, and can be good for up to about 24 hours, some of our burn colleagues tell us. If you're putting dressings on, that are non-burn dressings, we recommend dry gauze and not wet gauze. Wet gauze isn't really adding anything to the infection control. It's going to be no easier to take off when they eventually have to take the dressings down in a burn unit or a field hospital than a dry dressing, and it is going to put you at risk of losing a lot more heat through evaporation. So. Dry gauze is better than nothing. So sort of clean sheet, dry gauze, cleaning, debriding, and burn dressing are sort of minimum, better, best. The use of IV or oral antibiotics, like I said, is not primary for prevention in burn care. However, if you have a polytrauma patient with other dirty injuries, open fractures, open wounds, you then default to the combat antibiotics, which is probably your ertapenem first line for that. And then if it's a pure burn patient, we would hold off on antibiotics until they show signs of sepsis. So spiking fevers, signs of infection around the burn, redness, streaking, etc. At that point is when you would use your antibiotics. Hopefully they're out of your care by then. But if you're sitting on them long enough, or if it's a local national that you've decided to treat and take through this whole process, you would wait to give systemic antibiotics until you see signs of a local infection or sepsis. That's kind of, summarizes the key principles of burn care, airway, burn size estimation and severity, which is going to drive resuscitation, which is next, which is going to drive infection control, which is next, being vigilant for the risk of compartment syndrome in the extremities as well. Burn resuscitation flow sheets at the end of the slide talk and a cheat sheet, which you can refer to. The flow sheets are nice to have, but not a need to have. You can do a perfectly fine job documenting your resuscitation on the PFC flow sheet that's on the website, because it does have a place for pretty much all your ins and outs, all your fluids, and all your analgesics, and it gets it on one sheet rather than splitting it up onto two. So like I said, nice to have, but not need to have for the resuscitation flow sheet. One last thing I'll sort of talk about with resuscitation is if you're giving a lot of fluid and you notice you're getting complications, pulmonary edema or abdominal compartment syndrome, and I'll talk about that in a second as a really rare but feared complication of over-resuscitation, you can switch to more concentrated solution. And the thing that we normally switch to in a burn ICU is albumin. So if you can get 5% albumin, you can pretty much cut your fluid in half, right? Going from a liter down to 500 cc's. Plasma is good if you can get either frozen plasma or freeze-dried plasma is also an acceptable substitute for what we call a volume-limited burn resuscitation. And then finally, I'll just mention abdominal compartment syndrome because it is a feared complication, and this happens when a severely burned patient, and here we're usually talking 60% plus, has gotten so much fluid that they've third spaced into the abdomen to the point that all the soft tissue edema in the small bowel and the large bowel potentially compressed by third-degree burn over the abdomen itself, making that abdominal wall stiff. Then that pressure goes inward, and the things that it compresses are venous return to the heart, blood supply to the kidneys, so your urine output drops off, your blood pressure goes down. This is really something in a PFC environment that is best avoided and not treated, because the treatment is, you can decompress this with a nasogastric tube, maybe. Certainly if there's any air in the stomach that's complicating that, and that can be decompressed, that can help. And that would probably be the one time I would recommend taking the risk of putting an NG tube into a patient in a PFC environment without ability to document its placement. Because the only other thing you do is you do a laparotomy and you open up, and basically all of that pressure just comes out through the laparotomy incision, which is not something you're going to be able to do. So that's kind of it for an overview of burn resuscitation and the Joint Trauma Systems Burn Clinical Practice Guideline. I hope you enjoyed this talk and look forward to having a Q&A with Dennis about this and some other subject matter experts in the future.
That's another one for the books. Now take the challenge and go to the website www.prolongfieldcare.org and answer the questions linked to the podcast. Test your knowledge on the scenario and keep an eye out for the roundtable talk where we answer the questions and find out what an expert would do in the exact same scenario. I'm Dennis with the Prolonged Field Care Podcast. Out.